So I'm going to talk about the evolution of psychiatry over the last 150 years.
Talk into the mic.
Yeah, so if I can have the next slide, please. The focus of my talk today is to look at 3 paradigm shifts of psychiatry that have occurred in the last 150 years. Psychiatry what I call Psychiatry 1.0, emerged during the late 19th century and involved psychoanalysis. Psychiatry 2.0 focused on chemical imbalances that were addressed with medications and began in the mid-20th century. Psychiatry 3.0, which is where we are today, in my opinion, focuses on neuromodulation. We're focused on the neural pathways. And while this evolution or paradigm started in the 1980s, it is only now that it is becoming at the forefront of the treatment of psychiatric disorders. Next slide. Before talking about the 3 shifts, let's look briefly at the precursors to psychoanalysis, or Psychiatry 1.0. In the 4th century BC, Hippocrates thought that mental disorders were due to physiological imbalances rather than supernatural causes. His suggestion for treatment included diet, exercise, and a calm environment. Not bad suggestions, by the way, although I would add getting sunshine on your face shortly after waking would also be beneficial. In the Middle Ages, from the 5th to 15th centuries, mental disorders were thought of as spiritual crises and were addressed primarily through religious rituals such as exorcisms. In the 19th century, psychiatry was established as a medical specialty. Since that time, there have been 3 major paradigm shifts that I want to talk about. Slide. Before we talk about the phases of psychiatry, or the paradigm shifts, I want to describe a famous case study that we will weave throughout the homily. This is the Wolfman case. Sergei Pantaketchev was born to an aristocratic family in Odessa, Russia. He is the younger child in the picture with his older sister. From birth to 3.5 years of age, his parents described him as quiet and good-tempered, and these are their words, to the extent that they said he should have been born the girl and his sister should have been born the boy. From 3.5 to 4 years, he was described as being in his naughty phase. He was irritable and threw tantrums. On his 4th birthday, he had a dream of white wolves in a tree. This picture he drew for Freud to depict that dream. Immediately after having this dream on his 4th birthday, and for the next 6 months, he became constantly anxious. He was afraid of animals, even butterflies, and was worried about being eaten by a wolf. For a period of 4 years after this, he had obsessive religious piety and would perform elaborate prayer rituals. His behavior continued to deteriorate, and at 23 years of age, he was unable to effectively function, not even being able to dress himself. His family history was marked by the suicide of his father and sister, and the relationship with his mother was described as cold. So, Psychiatry 1.0. Sigmund Freud is the founder of psychoanalysis, and this is where the first phase of psychiatry begins. The therapeutic approach in psychoanalysis, and that of Freud, explores the unconscious mind to uncover repressed feelings and emotional patterns. Freud asserted that neurotic problems in later life were a product of conflicts that arose during the early phases of development. Neuroses could be cured by making conscious the unconscious thoughts and motivations, thereby gaining insight. Therapy created the right conditions so the patient could bring conflicts into consciousness where they could be addressed. By having a cathartic, that is a healing experience, the patient could be helped and cured. Techniques included dream analysis, free association, and transference. Transference involved patients projecting feelings about significant people in their lives onto the therapist, thereby revealing underlying issues. So how would psychoanalysis address Wolfman? Sergei began therapy with Freud in 1910 at the age of 23 years. He remained in therapy until 1914. During this 4-year period, he would spend up to 18 hours per week with Freud on the couch. In psychoanalysis, therapy occurred with the patient lying on a couch facing away from the therapist. As indicated, techniques included free association, dream analysis, and transference. And the idea was that if the patient could not see the therapist, the patient was much more likely to express transference and free associate than if they had been facing each other. Sessions occurred several times per week and often for years at a time. Freud interpreted the wolf dream to mean that Sergei had possibly witnessed his parents involved in a primal scene, and this contributed to his neuroses. The case highlights Freud's theories on psychosexual development and the unconsciousness. Sergei returned to psychoanalysis several times after this initial set of sessions with Freud, with each lasting several years. Since Freud's time, a number of different talk therapies have been devised, with the most common being cognitive behavioral therapy. Unlike traditional psychoanalysis, CBT tends to occur in the short term with maybe 16 or so sessions, and the focus is on the relationship between behaviors, thoughts, and emotions rather than the unconsciousness. Studies suggest that 60 to 90% of patients derive a positive benefit, although not necessarily full remission, from traditional psychoanalysis. The cost in terms of time and money, however, can be excessive. The new talking therapies, like CBT, have a range of efficacies from 38 to 82% within the first year, depending on the mental disorder being treated. Relapses may occur after that time. Psychiatry 2.0, neurotransmitter depletion theory or chemical imbalances. Neurotransmitters play a crucial role in regulating various brain functions, including mood, cognition, and motivation. Imbalances in neurotransmitter activity, according to the theory, can lead to significant mental health challenges such as depression and anxiety. There are 3 main types of neurotransmitters that are the focus of chemical imbalance models. The first is norepinephrine. This is both a hormone and a neurotransmitter that plays a crucial role in the fight or flight response by increasing alertness, blood pressure, and heart rate during stress. Dopamine is a neurotransmitter in the brain that is involved in learning processes and maintaining focus on tasks, mood regulation, and contributing to feelings of happiness and motivation, as well as regulating movement and hormonal regulation and sleep. Serotonin is often referred to as the feel-good chemical that helps us regulate mood and emotional well-being. Low levels are associated with depression and anxiety. It also plays a role in sleep. 90% of serotonin is found in the gut, where it regulates bowel movements and digestion. It also influences appetite, sexual desire, and blood clotting. Serotonin is synthesized from the amino acid tryptophan, which is found in foods such as salmon, eggs, and cheese. Exercise and sunlight can also stimulate the release of this amino acid. In the 1950s, tricyclic antidepressants were discovered while researching antipsychotics, and they were later found to be effective for treating depression by allegedly increasing serotonin and norepinephrine levels in the brain. And so amitriptyline is an example of a drug that is a tricyclic that was beginning to be prescribed in the 1950s. In the early 1980s, SSRIs, or selective serotonin reuptake inhibitors, were discovered. The premise of this class of medication was to leave more serotonin in the synapses, or regions between the neurons. Prozac was one of the first to receive FDA approval and became available in 1987. In the late 1990s and onwards, atypical antidepressants came to market. These are referred to as serotonin norepinephrine reuptake inhibitors, or SNRIs. Examples include medications like efficacy and Prestige. I refer to them as the big boy drugs. They are usually prescribed to people who are quite severely ill, but they also have very significant side effects. One of the criticisms of the chemical imbalance model is that we do not actually know if there's a lack of certain neurotransmitters, nor whether medication effectively increases the availability of the transmitters to the neurons, or synapses. That is, the underlying causes and effects of mental disorders are complex and involve interactions with other biological, psychological, and environmental factors. Additionally, these classes of medications take 3 to 6 weeks to reach efficacy. All come with a variety of side effects, including gastrointestinal distress, headaches, a flattening of mood, decreased libido, sleep disturbance, and weight gain, to name a few. These side effects also can persist even when the medication is stopped. Physiological dependence may occur. Once prescribed, patients often take them for many years and, in fact, find they experience a rebound effect if they stop the medication. Research suggests that responses to these medications, regardless of the type, are not significantly impacted by dosage, and only 30% of patients have a positive response. Under the chemical model, imbalance model, Wolfman would have been prescribed antidepressant medication, and likely citalopram, to address his overwhelming anxiety. When side effects occurred, and they most certainly would have, additional medications would have been prescribed to manage the unwanted symptoms. If he had been prescribed medication, relapses also would not be unexpected. Psychiatry 3.0, neuromodulation therapies. What is repetitive transcranial magnetic stimulation, or RTMS? This was developed in the 1980s, building on the Faraday principle of electromagnetic induction. That is, a changing magnetic field can induce an electric current in a circuit. Using Faraday's principle, a magnet can induce an electric current in the brain, a closed circuit. While RTMS has been around since the 1980s, it has not been widely used because of difficulty in brain mapping, so the electric current has to be induced in a specific area of the brain to be effective. As well, magnets became excessively hot, and the procedure was usually painful. In about 2014, a research program at Stanford University headed by Dr. Nolan Williams began to look at RTMS in the treatment of resistant depression. Using sophisticated imaging techniques, Williams and his team found that the dorsolateral prefrontal cortex, highlighted in blue on that brain, was underactive in depressed patients. So it just wasn't firing to other areas of the brain compared to healthy adults. This area is important in planning, inhibition, and initiation of behaviors and judgment. Additionally, what Williams and his team found is that in those treatment-resistant patients, the relationship of the dorsolateral prefrontal cortex was inverse with the cingulate. The cingulate is a little area of the brain that sits right under that blue area and is it's responsible for fight or flight responses, emotional regulation, and motivation. In the depressed patients, Williams found that the cingulate was sending signals to the dorsolateral prefrontal cortex. This is the opposite of what they found in healthy individuals. So a good metaphor is to think about the dorsolateral prefrontal cortex as the coach of the brain and the cingulate as the hockey players. So in depressed people, the hockey players are telling the coach what to do rather than the coach telling the players what to do. So a real life example might be you're walking down the street and up ahead you see a barking dog. If your cingulate is driving behavior, you would feel scared and maybe begin to run away in the opposite direction. If the dorsolateral prefrontal cortex is in control of the cingulate, as it should be, you might acknowledge there's a potential for danger, but with equanimity, you assess the situation and realize, okay, the dog's not that big, and it's behind a fence. So probably the danger is probably quite minimal. So with having that reverse with the cingulate in charge of the dorsolateral prefrontal cortex, the whole system becomes overreactive, hypervigilant, and ineffective. What is so exciting is that the RTMS therapy corrects the relationship between the two regions of the brain by stimulating the dorsolateral prefrontal cortex, allowing it to send and strengthen pathways going in the right direction. Williams' team enrolled patients who had tried every treatment. They'd been on antidepressants for years, decades in fact. Some had even had treatments such as electroconvulsive therapy or ECT. In his most recent studies, so he's published these in October of 2025, he used high-intensity magnets over the course of 1 week sessions. These patients had multiple sessions a day, and they were hospitalized, but for 1 week they received these multiple treatments. What he found is that for a significant proportion of the patients, after day 1, they were already beginning to feel better. 78% had a complete remission after the week of treatment. And so the patients, they refer to first responders who experienced something positive after day 1, and they were very likely to have, for those first responders were very likely to have a complete remission at day 6. And I cannot explain how truly remarkable this is. These are people who were incapacitated. They were not functioning. They were not working. They were on disability. They had been like this for decades. They did not find joy. They were existing basically. One of their patients continued to be in complete remission 4 years after treatment, and they're continuing to follow him. The changes in these patients were so profound that Williams had to include social workers and therapists on his team, because now these people needed help navigating their new lives. Some of them had been married in relationships, but the whole marital dynamic was that one of them was ill. And now suddenly you have someone who's well, interested in having a sexual relationship again, interested in contributing to the household, interested in finding meaning through work, for example. So this treatment has been shown to have very profound effects. New technology has fixed some of the old problems of the machines. Today, RTMS is painless and brain mapping can be done in seconds. Because it is a non-invasive procedure, nothing is being done to the brain. The brain is creating its own electrical currents with the magnet. Few patients report any side effects. Should Wolfman come into my own clinic, I would have administered sessions of RTMS using the ExoMind machine once a week for 6 consecutive weeks, with each treatment lasting 24 minutes. If necessary, booster sessions would occur at 3, 6, 9, and 12 months at one session each. In my own experience, patients respond positively after one session, and similar to the research by Williams, most or 3/4 after 6 sessions. They often tell me they have clarity of thought, the noise in their head vanishes, they have a more even mood, and improved sleep. And one of my patients has said colors seem brighter after each session. Compared to the time and cost, both in terms of money and side effects, RTMS is proving to be highly economical. The 1990s were declared the decade of the brain. Few gains, however, were discovered in this decade. I believe that Psychiatry 3.0 will truly be the decade of the brain. I'm most excited about how RTMS can be applied to depression, anxiety, attentional issues, and they're now looking at how it can impact concussion or post-concussion syndrome. With this technology, the brain is repairing itself. In addition to RTMS, the future of psychiatry will incorporate substances such as ibogaine and ketamine treatment to address PTSD in veterans and first responders, as well as with those with other psychological disorders. This work is already being done and showing great promise. And I saw yesterday in the news that the FDA in the States is really pushing the ibogaine treatment forward. Thank you for this opportunity to speak to you today, and I look forward to having a spirited discussion during the forum.